It's kind of cool. We're going over both the respiratory system and the immune system back to back during this whole fiasco right now. Come on. There you go. Show this little GIF. It's a very old GIF, but it still works out. I still love it. I'm not getting rid of it. I don't care. All right. So with the respiratory system, we've been kind of touching on it when we talked about the cardiovascular system. We said that when we go from the heart, when we exit the left ventricle, we enter the aorta. Oh no, backtrack. When we're in the right ventricle, we enter your pulmonary trunk. From the pulmonary trunk, we enter your pulmonary arteries. And pulmonary arteries head to what organ next?
Lungs.
The lungs, where what occurs?
Gas exchange.
Gas exchange, very good. So we've talked about gas exchange a little bit in the previous chapters, right? So now we're going to really talk about it. Okay. Now, before I start going over this, if you hear these two terms, when you hear the word pulmonary or you hear the word pleural, that's going to refer to something with the lungs. Okay, something lung related. Okay, when you hear pulmonary or pleural, it's something lung related. Okay, in almost any context. Okay, now because we're in the respiratory system, we're going to have to split hairs here, and there is a difference between the two. You'll see in part 2 on Thursday. Okay, but when you hear pulmonary or pleural, that refers to something lung related. So if you hear about something called like pleural effusion or pleurisy, or you hear about pulmonary edema, pulmonary embolism, right? You know it's going to be something lung related. Okay, pulmonary pleural. All right. So we know that the respiratory system functions in supplying the body with O2 and getting rid of CO2. Okay, we've been over that before. All right, we talked about gas exchange. Okay, we know this. Okay. Additionally, the lungs also assist in olfaction and speech production, right? So if you speak Spanish, like you've seen this word before, more or less, right? So olfaction is what?
Smell.
Good, very good. Sense of smell. Sense of smell and speech production. And if you play God of War, the current one, in God of War, there's a head, like a head that's like literally on the hero's belt, and the head's speaking the whole time. It's like, wait a minute, you can't speak, you don't have any lungs. How's the air going to come out? So system olfaction and speech production. And here are going to be the 4 steps of respiration. Okay, respiration is essentially going to be how we breathe, right? So the first step in respiration is going to be something called pulmonary ventilation. Okay, pulmonary ventilation. What this refers to is air moving into and out of the lungs. Okay, that is pulmonary ventilation. Okay, simply air moving into and out of the lungs. There's no gas exchange occurring. Y'all see the weather outside? It's so wrong. I saw a meme that said, man, Texas is looking all beautiful right now, like it wasn't trying to kill us about a couple days ago. Messed up. All right. External respiration refers to the exchange of gases between the lungs and the blood. Transport of respiratory gases is a bit wordy, but what this means is exactly what it says there. It's going to be movement of gases throughout the vasculature, your blood vessels. No gas exchange. Okay. So in your arterial system, what gas would you expect there in high concentrations in the arterial system usually?
O2.
O2, right? O2, very good. And in the venous system?
CO2.
CO2, very good. So it's simply moving gases throughout the body. That's all we're doing. We're just kind of trucking it around, right? All around the body. That is transport of respiratory gases. The name kind of explains itself. And then finally, in internal respiration, this is the exchange of gases between the blood and the tissues. It's funny, this is the last chapter that we presented last semester before we went to, I think, spring break before COVID hit. This brings back some bad memories here. I had my class for half a semester and then I never saw them again in person. We were supposed to do, for those of you that have worked in clinical stuff before, we were supposed to do spirometry. Have y'all heard of that before? Spirometers, where you essentially test a person's breathing ability, right? And what we do is we have these little disposable little mouthpieces, and we use like common kind of spirometers. So you just take off the mouthpiece, or you put the mouthpiece on spirometer, and then we blow into it, and then we do our whole lab. But when we heard word of the coronavirus thing coming over, it's like, let me go and hold off on this lab. I don't want to be responsible for giving people COVID. Because we were sharing devices. So I was like, nah, well, let's kind of stop that. Okay. So when you look at these four processes of respiration, whenever you see patterns, make sure to kind of point them out and exploit them. Okay. So for example, to my eyes, whenever I see pulmonary ventilation and I see transport of respiratory gases, number 1 and 3, I really see the bulk movement of gases. Okay. We're just simply moving gases around. That's what I see. When you look at 2 and 4, that is gas exchange.
With 4, is that the blood coming from the left side of the heart?
It's all over the body. So we could be talking about the capillaries in your arms or the capillaries in your foot. Okay. So again, whenever you see patterns, make sure to point them out and then exploit them. It's much easier to remember them that way. If you had me for A&P1, y'all remember this? Remember that? ROSL? Foramen rotundum, ovale, spinosum, lastrum. Y'all remember that? If you had me for A&P1? Okay. So
That would be good to know.
Yeah, the holes of the skull were no joke. And so you had to be very clever about it, because even I do not like teaching skeletal system. I do not. But you had to use every trick that you can to memorize these things. So that was one of the things. But again, whenever you all see patterns, just exploit them. Okay. All right, everybody cool with that? 4 process of respiration? Okay, very good, very good. Again, stop me if you have a question or if you need me to slow down or repeat something. Okay. All right, let me switch these out. I don't like the way this is. Hold on, bronchi. Fine, bronchi, lungs. I should have been switched. That was my bad. All right, so what we have here in this little pyramid is we have basically the hierarchy of the respiratory anatomy from superior to inferior perspective. So this is superior, this is inferior. Okay, I'll give you a second to kind of write this down. While you're writing this down, check this out. Everything in kind of this dark blue over here is considered part of the upper respiratory system. Everything in this kind of dark purple over here is represented as the lower respiratory system. And then the larynx, which is colored in this kind of light blue, is actually part of both. Okay, so I'll give you a second to write this down if you want to write it down. Okay, let's go ahead and start off from the superior perspective. We'll start off at the nasal cavity. Okay, so what we have here is we have the nasal cavity right over here, covered in mucous membrane, obviously, right? Covered in mucous membrane, and we have the oral cavity over here. Okay, also covered in mucous membrane as well. And as we established in the immune system, the two most common routes in which pathogens can invade you are usually either through the nose or through the mouth. These are the most obvious openings of the body, right? So again, it makes sense that we have MALT, or mucosa-associated lymphoid tissue, scattered about the mucous membranes, right? Over here, we have your tonsils right over here, here, and down here. Again, these are going to be parts of your immune system, just waiting for pathogens, just trying to catch them, okay? So in the nasal cavity right over here, we have a couple different structures in the nasal cavity. The first one I'm going to cover are going to be the nasal conchae. Nasal conchae, which are also called turbinates. If the book refers to as turbinates, I'm not sure. But these are going to be structures that are kind of like folds that are within your nasal cavity that help to kind of slow down and help to circulate air. Okay, so think of it like this. If you didn't have these turbinates, and we're going to talk about sinuses in a second, think about kind of like an alley, right? Like here's a building here, and here's a building here, and there's an alley in between. Does that make sense? There's an alley right in between. And as air passes through this alley, it's just going to go right through, like that. Make sense? If your nose did not have those conchae or those sinuses, air would just go right through. But instead, this alley that we're talking about has, for example, there's a dumpster there, there's a trash can there, there's a couch there. So when air goes through it, it doesn't go straight through. It kind of like goes up diagonally to the side. It kind of like gets disrupted. Does that make sense, y'all? We're kind of slowing down the air's pathway. And so by slowing down the air's pathway, it does not go completely through. Now that's important because we usually do not want cold, dry air to enter into the back of your throat or your lungs. Okay. For those of you that exercise, for those of you that run, one of the first things they kind of teach you is don't breathe through your mouth. Right. even though we all kind of do it, guilty. Doing one of those things, okay? The problem with that is if you breathe with your mouth too often, it dries out the back of your throat, okay? You may have done that when you're sleeping as well. Maybe you leave your mouth open when you sleep, like that. Have you ever taken a picture of your partner, your girlfriend or boyfriend while they're sleeping? Take a picture of them. That's your job, right? So what that does is if you look at the mucous membrane, right, we're creating mucus because we do not want the underlying tissue to dry out. If that underlying tissue is exposed, it's exposed to cold air and pathogens, and now there's nothing stopping pathogens from invading, there's nothing stopping these cells from being damaged. So you always want some mucus here. So if we have cold, dry air coming in, it's going to dry out the mucus and leave our tissues exposed, the underlying tissues exposed. So the job of the nasal conchae, as well as the turbinates, okay, nasal conchae, as well as the sinuses, what they do is that they are highly vascularized. What does that mean? They're highly vascularized.
There's a lot of blood vessels and stuff like that in them.
Very good. There's a whole lot of blood vessels. One thing that people don't really talk about that we talked about in chapter 1 is that blood also carries heat. Blood carries heat. And so what happens there is that as this air circulates in your nose due to the conchae and the sinuses, what happens is that air becomes warmed. It becomes kind of humidified, right, by the vasculature that's there. Does that make sense, y'all? The sinuses and the conchae help to kind of humidify the air. They warm it up. They add humidity to it. Here it is here. Here it is here. Okay, so that is the purpose of these conchae. Nasal conchae, they're also called turbinates, I believe. All right, they're highly vascularized. They help to kind of slow down air and help to humidify it. Okay. Now, the other thing I was talking about as well were sinuses, right? So here are your sinuses that you probably learned from A&P 1. They're simply these spaces that are going to be in your skull. They're these spaces, okay? And they serve a couple functions. Number one, they help to add to your voice quality, right? Because if you have sinusitis in which your sinuses are inflamed, how do you sound? You have a head cold. How do you sound? You kind of sound like this, right? I got a cold out, feels so good. Does that make sense? Okay, so if those sinuses are inflamed, that really does affect voice quality, okay? The other thing that it does, much like the conchae, it helps to kind of humidify and kind of moisten and warm the air, okay? So these are gonna be your sinuses right here. They have overlapping functions. Okay, let me show you a quick video on, I think, sinus draining. We're gonna drain the sinuses.
Two issues going on. So I had two issues going on. One was sinus pain all the time, and then I would have bronchitis every 3 months. On the day, every 3 months. For 32 years, I dealt with the pain. It was pain and then bronchitis, and I would get bronchitis 4 times a year. And again, I could peg when it was going to happen. I was going to my primary care physician for the last 5 years or so, and we tried everything. Antibiotics, we've tried Claritin, over-the-counter stuff all the time, and it just wasn't getting any better. And so my primary care physician said, hey, why don't you go and see Dr. Ragsdale?
Many patients would benefit from the balloon sinuplasty procedure. The ones that we're usually recommending a procedure are the ones that are having several infections per year, or someone that has chronic sinus problems where they always have pain and pressure.
So Dr. Ragsdale recommended the balloon sinuplast and asked me to do some research and asked me what I would feel comfortable with it. And I did, and I did.
When we use the balloon procedure, it's all done on a monitor with a scope. It's the only thing in the nose. It shows the anatomy on a large screen. We then use a guide to guide the lighted guide wire into the sinuses. Once the light is in the sinus, it glows, so we know that we're in the right place. We then can advance the balloon. Once the balloon's in the proper position, we inflate the balloon for a few seconds. At that point, the sinus opening has been dilated. It creates a long-lasting opening. The bones of the sinuses are actually expanded, so we're not just dilating swollen tissue. Once we've finished with the dilation, we'll go ahead and irrigate the sinus with saline, and then we remove the balloon and go to the next sinus.
I have not had bronchitis once. I don't have the sinus headaches at all. I don't dread getting on the plane. I don't have to suck down Sudafed 6 times a day. So things are really, really cool. I play golf. I love golf. I love being in the outside. I no longer dread which golf course I can go to. I don't have to plan ahead and be sure there's not pollen for the day, etc. It is really awesome.
All right, so it's a bit of sinus irrigation there. Another extreme form of getting rid of these kind of chronic sinus infections is going to be actually to remove the bone that's associated with that area. It's pretty crazy. So does that make sense, y'all? What sinus is and what conchae do? Okay. All right. So nasal cavity, paranasal sinuses, I think we're good. Now we're in the oral cavity. Okay, right over here. So we're going to be in these 2 regions right over here. So now that we've discussed the nasal cavity and we kind of point out the oral cavity over here, there's a tube all the way back here. This tube is called the pharynx. Okay, this tube is called the pharynx. Back here, all the way back here. It is a common tube for both breathing as well as eating. Okay, it's called the pharynx. Right over, it's this pharynx right over here. Okay, that is the pharynx. Now, for the practical next week, I want you to be very careful here, okay? What happens is a good 60% of students, I'm just talking from experience here, 60% of students will miss the following questions. You ready? All right. The pharynx is split into 3 divisions. The nasopharynx, right over here. Okay, I'm going to just draw it out. Okay, I'll just point it out. The nasopharynx, which is right here. Okay, obviously the nasopharynx is a part of the pharynx that is going to be associated with the nasal cavity, right? Great name, nasopharynx. So if I point up here, don't just put pharynx, that's not specific enough. I want to hear nasopharynx. Okay, I'm telling you, 60% of students reliably get these wrong. I don't know why. Okay, nasopharynx. When you get down over here, down to the mouth, that part of the pharynx is called the oropharynx. Again, it's great because oral cavity. Oropharynx. And by the way, I'm not trying to make fun of anybody, but you want to pronounce these as like larynx or pharynx, okay? Because just the way it's spelled, some people say pharynx, and I think what they're doing is they're switching the N and the Y, right? So just be careful with that one. So larynx, pharynx later on, okay? So this is the oropharynx right over here. And then down over here, we have another portion here called the laryngopharynx. Okay, the laryngopharynx. We'll take a break in a bit. Okay, the laryngopharynx. Now, once you get down to the laryngopharynx, this is where we're going to have this kind of split in between the respiratory system and the digestive system. Because once you get down over here, If you go ventrally, you continue through the respiratory system via the larynx. Okay, so ventrally, we continue with the respiratory system. Dorsally, if we continue down, now we're going to hit the esophagus, and that's part of the digestive system. Okay, ventrally, we're going to the respiratory system. Dorsally, we're going to the esophagus and the digestive system. Okay, any questions on the pharynx? Freddie, any questions, man? No?
So will the oral cavity be covered both in a digestive standpoint and a respiratory standpoint for practical reason?
Yes. And I'll try to be specific on that. Yeah. But yes, it's used for both.
I actually got a question. I just don't know how practical this question is.
Sure.
They're saying how like you either like move around the bones in the nose to like if you have sinus problems. Does that mean like if you get a broken nose, you can mess up your sinuses?
Yeah, certainly.
Oh, okay.
Yeah, certainly. Yeah, you can totally have breathing problems. There's I watch the UFC, and geez, they get their faces broken so many times. Their orbital bones, they get their nose broken all the time. And there's one guy in particular, his name is Vanderlei Silva, and he's been in so many fights. And he kind of sounds like this now. He's had so many surgeries on his nose. That's how he sounds like now. So totally, man. All right. Okay, let's go ahead and discuss the larynx really quick, and then we'll take a 5-minute break, okay? All right, so right after the pharynx, okay, the 3 divisions of the pharynx, we move on to the larynx, okay? The larynx, or all the way down over here, is considered what we call the voice box, right over here. Consider the voice box, right? That's kind of the colloquial term for it, the voice box, okay? So as soon as you exit the laryngopharynx, now we're in the larynx, right over here. Now here's gonna be another question that students miss all the time. You ready? If I point to this very first structure right over here, right after the laryngopharynx, most students will say that this is the trachea, okay? That is way too high for the trachea, okay? Have you all heard of a tracheotomy before, right? Tracheotomy, tracheostomy, okay? So if you look at your laryngeal prominence right over here, this guy right here, okay, that is part of your larynx. So if I point all the way up here and say, okay, we're gonna do the tracheotomy all the way up here, that's the wrong area. Does that make sense? This is gonna be your larynx. Below your larynx, that's gonna be your trachea all the way down here. Okay, so this is called the laryngeal prominence. It really sucks to shave down here. You never wanna cut your, oh man. My girlfriend, her legs get weak whenever I start shaving, and I'm like right here. Any of you ever shaved with a straight razor before? You have? Freddie, you have? Anybody else? I'm too scared. I'm too much of a baby to get a straight razor. Cause of death. Try to be too fancy.
And they look cool too. So.
They look super cool. They look super cool. I think to be a full-on barber, you have to know how to do the straight razor. So some Sweeney Todd action going. All right, so that is the larynx, okay? Now, there's a structure that's superior to it that a lot of us know, and that is called the epiglottis right over here. Does anybody know what kind of cartilage the epiglottis is made out of? Anybody remember from AP1? Will, do you remember? Go ahead, anybody?
Was it elastic cartilage?
Very good. It's elastic cartilage. Excellent. It's elastic cartilage. Okay. Where else is elastic cartilage found? Very good. It's found in the ears. That is elastic cartilage. Those are the only 2 places. They all have a whole lot of elastic fibers in them. Very good. So by default, the epiglottis is open. Why do we want that? Why do we want the epiglottis to be by default open?
So you can breathe?
Yeah, so you can breathe. I mean, how often are you breathing? hopefully, hopefully all the time, right? So that's going to be the epiglottis. It's by default, it is open, okay? Whenever we swallow, right, food, drinks, whatever, what happens is the muscles of the tongue and the muscles of the throat will pull this guy closed. So when it gets pulled closed, I'll kind of make that our epiglottis right over here. When it gets pulled closed like this, now food and drink and whatnot are going to bypass the larynx and go straight down and slide into the esophagus. Does that make sense, y'all? So as soon as you swallow, the muscles pull the epiglottis closed, and now food and drinks are allowed to enter into the stomach. This is why you don't want to like talk and eat at the same time, because when you're talking, your epiglottis is open. And when you're eating and trying to swallow food, you're trying to pull it shut. So if you're eating both at the same time, food can literally go down the wrong tube, and now you get one of those. Now it's embarrassing. You're in front of the whole restaurant, and people are just looking at you. But food can go really deep down in there, even down all the way down to the trachea. So you want to be very careful about that, about eating and talking at the same time. One of the more embarrassing ones that everybody's done is you're just sitting there on the couch and you swallow your own like saliva, but it enters the wrong tube. You just start coughing for no reason. Oh my gosh. Y'all do that too, right? Okay, all right, just making sure, All right. Any questions on the anatomy so far, all the way down to the larynx? Any questions on that? Good. Okay, let's take another break. I'll see y'all again at 12:30. We're going to finish this up. Okay, 12:30. See you in a bit. All right, let's continue our journey down the exciting respiratory pathway. Okay, so the pharynx, I think we already covered it. Epiglottis, we're good. Okay. Again, here's your laryngeal prominence right over here. This is part of your larynx. So if you were touching your laryngeal prominence right over here, that is going to be still part of the larynx. Inferior to the larynx directly, about a half an inch below, is going to be something called your thyroid, which we'll go over in late April. That'll be the endocrine system. So see you then, right? The thyroid right there. All right. Yeah. All right, now a little bit more on the larynx, okay? Now the larynx is also known as your voice box, okay? The larynx is also known as your voice box. And there are false and true vocal cords located in your larynx, okay? Now, anatomically for the practical, you do not need to know the location of these vocal cords, right? You do not need to know them. I should have you know them, but nah, I'm not feeling it. But there are both false and true vocal cords in your larynx, okay? What happens is that everything superior to the false vocal cords is part of the upper respiratory system. Okay, and with the true vocal cords, everything inferior to the structure is part of the lower respiratory system. Okay, the false vocal cords are actually superior to the true vocal cords. Okay, it's for this reason why the larynx is part of both. Okay, so here they are over here. Actually, let me just go ahead and play a video on this. Hold on. I have a video for you here.
On average, adult men's voices have what's known as a lower fundamental frequency than adult women's voices. The fundamental frequency is simply the scientific term for how high or low a person's natural speaking voice is. Sound frequency is measured in hertz, which means how many times something happens in 1 second. So a sound wave that vibrates 100 times per second produces a tone of 100 hertz. The more cycles per second, the higher the pitch. Babies usually cry at a frequency of around 500 hertz. Children have speaking frequencies in the range of 250 to 400 hertz. By the time of adulthood, however, men have an average fundamental frequency of around 125 hertz, and women about 200 hertz. So what happened here? Why the hertz gender gap? Leading from your lungs to the cavity behind your mouth and nose is a pipeline called the trachea. You use it to breathe. At the top of the trachea is a hollow organ called the larynx, or in common parlance, the voice box. There are several factors that can all have some effect on the fundamental frequency of a person's voice, like the size of the larynx and the differential development in facial bone and cavities in the head. But the most important factor to talk about is the length of the vocal folds. If you pluck a string, the length of the string affects the frequency that note plays. Think about a guitar. When you press a string down to a higher fret on a guitar, you shorten the length of the part of the string that vibrates when you pluck it, and this produces a higher note. Same thing happens inside your larynx. During puberty, both boys and girls experience growth of the vocal folds, leading to lower voices. But the male hormone testosterone, which is released by the testicles during puberty, typically causes boys' vocal folds to grow longer and thicker than girls. On average, adult women have vocal folds somewhere around 10 millimeters long. Not bad, ladies. While adult men have vocal folds in the neighborhood of 16 millimeters. Consequently, women are up there on the upper fret, soloing into oblivion like a high school kid who just learned to play Eruption by Van Halen. And men are letting the open strings ring like the intro to Nothing Else Matters by Metallica. You know? You know? Bonus fact, everyone...
Yeah, she's a character. So with your larynx, it contains your vocal cords. Again, you do not have to locate them anatomically. Right over here is going to be this kind of white part over here is going to be your true vocal cords right over here. And then right over here on kind of the lateral portion, that's going to be your false vocal cords. Okay, but you don't need to know them. Don't worry about them. Just know that they are there in your larynx. Okay, and the way it works is that as air rushes past the vocal cords, they're going to vibrate, and depending on the length of your vocal cords that she was just talking about, that'll help determine your kind of voice quality. Okay, if for some reason the vocal cords are going to be inflamed, well, then we call that laryngitis. Does that make sense? Okay, remember when we said itis, things are swollen and they don't work as well. All right, so if you speak for a long period of time, kind of like I do, not to make it about myself, your voice starts to go out, and then it's the quality is not the same. Okay, y'all want to see something kind of weird? I thought this was fake. I saw this, I think it was on Instagram, and then I saw it again. I looked it up here. So remember, the shorter the vocal cords, the higher the kind of the pitch and frequency, I believe. The higher the frequency, the longer the vocal cords, the deeper the voices. This guy over here, he has some form of acromegaly. I think some form of acromegaly, in which basically he has too much growth hormone being produced, and all the structures in his body get like huge. I mean, if you look at him, he's like a giant person, right?
Su cuerpo. Los gemelos afrontaron infinidad de extrañas enfermedades, pero Rodrigo nació con su caja torácica muy grande, por lo que falleció cuando tenía 1 año y medio, mientras que Javier siguió luchando por su vida.
Porque pues ellos nacieron con un...
Okay, now listen to his voice. Check this out.
Síndrome.
Osteoporosis y problemas para hablar, pero en forma milagrosa se libró de la muerte y ahora intenta llevar una vida lo más normal posible.
Bueno, aquí en la casa pongo la mesa, quito la mesa, doblo la ropa, la reparto, la ropa que está planchada, la reparto, ayudo mucho a mi mamá, cuido a mi abuelita.
Javier mide 2
Poor guy. Wasn't that insane? That voice? Jeez. And again, it's because the length of his vocal cords are just so much longer than everybody else's because of his condition. So I just thought I'd kind of show you that. I just thought it was nuts. Okay, everybody cool on the larynx? Yes? Okay, larynx right over here. All right. We're going to cover the trachea and the alveoli, and then we're done. Okay. So the trachea is going to be inferior to the larynx. Okay. So here's going to be your larynx right over here. Okay, your larynx right over here. This is the epiglottis right over here. Larynx right over here, and then down over here is going to be your trachea, all the way down here. Okay, and the trachea, okay, is going to eventually lead into the lungs. Okay. Now, really quickly, let's talk about the tissue makeup of the trachea, right? So we're going to find out that the trachea is made up of the following primarily. Okay, it's made up of hyaline cartilage. It's made up of one of our favorites, pseudostratified, ciliated, columnar epithelium, and smooth muscle. Okay, these are going to be the three most important kind of tissues that make up the trachea. Makeup. Okay, hyaline cartilage makes up the structure of the trachea, right? If we look at the trachea, okay, it makes up the primary structure of the trachea right over here. See, everything that you see here in blue is kind of what we call cricoid cartilage right over here. These rings here are all made up of cartilage, hyaline cartilage specifically, even in the bronchi as well. We'll discuss that a little later on. But the cartilage makes up the basic structure of it, okay? What happens is within the mucosa of the trachea, we have an old friend from ANP1 called pseudostratified ciliated columnar epithelium, okay? The main thing here is that these cells are ciliated. And what do cilia do?
Propel things along.
Okay, they propel things along, right? If there's any kind of mucus or debris, if you all know what crowd surfing is, right? Essentially cilia do this, and then debris and mucus kind of like get propelled upwards to get to the esophagus, right? So the trachea as well as the bronchi are going to be ciliated, right? This many of the cells in the mucosa, okay? And the other thing that the trachea is made out of is as well as smooth muscle. So we know that smooth muscle can contract and relax, right? I think we've discussed that with vasodilation, vasoconstriction. Okay, let's just go over that one more time. Okay, so if you have a regular blood vessel here, right, and get out of here, and it vasoconstricts, right, it gets smaller. Everybody remember that? If a blood vessel get out of here. If a blood vessel vasodilates, it looks like this, okay? And that was all due to the tunica media. Y'all remember the tunica media? That is the smooth muscle layer of your blood vessels, right? And so in here, we had a vasoconstriction, and that was caused by smooth muscle contracting. Over here, we had vasodilation. This should be a review, and we had smooth muscle relaxing. Does everybody remember this? Hopefully. Okay, good. Now, here's what happens. When you talk about the respiratory system, especially in the trachea and the bronchi, I'm getting ahead of myself. What can happen is we can have a constriction and a dilation of these airways as well. Okay. So I don't know if you could call it tracheal constriction, but you have constriction dilation in the airways as well. So if for some reason there's anything that causes your smooth muscle to kind of contract, the airways will close, right? Or they swell up, they're going to close, okay? Have y'all heard of anaphylaxis before? Anaphylaxis? Okay, good, all right. So here's what happens with anaphylaxis. So just put your pencils down, just kind of listen for a second, okay? So what happens is that some people are severely allergic to some things, right? For example, peanuts. Everybody with me so far? They're allergic to peanuts. And so they're deathly allergic to peanuts. What happens is when they're exposed to this allergen, what happens? One of those things, right? Their throat starts to close, okay? Now, the reason for that is because if you go back to the immune system, your basophils, eosinophils, and mast cells, all three of those cells are responsible for inflammation. Does that make sense? They're responsible for inflammation. So what happens is, if this, for example, is a mast cell or a basophil, right, and it has a receptor for a peanut, right, that peanut comes along, binds to this basophil or mast cell, and what occurs is something called degranulation, in which all the histamine comes out. Histamine, histamine, histamine. What do we associate histamine with?
Inflammation.
Inflammation, very good. That's why you take Benadryl and stuff for the antihistamines. Does that make sense? Okay. So what happens is that when you release histamine onto the blood vessels, okay, what's going to happen is they're going to swell up. Does that make sense? The blood vessels are going to swell up. So this occurs. Histamine, right? Inflammation, blood vessels swell up. Does that make sense? Okay. So remember, they swell up in order to allow white blood cells to more easily pass through them. So long story short, they swell up when they're exposed to histamine. So what happens is blood vessels make up your trachea, they make up your bronchi, obviously. And think about it, as these blood vessels expand, here's going to be your airway. If they expand and expand like this, okay, what happens to the airway? It gets much smaller. Does that make sense? They get way smaller.
Closes.
Yeah, they start to, or even close totally, okay? So when when you have significant vasodilation, you have a closure of the airways, okay? It's for this reason why a lot of folks that have anaphylaxis carry on EpiPens, because when epinephrine binds to your blood vessels, that causes a vasoconstriction, right? So if your blood vessels vasoconstrict, constrict, the airways start to open up. Everybody with me so far on that? Okay, so the problem was initially inflammation, and the solution is to kind of vasoconstrict them to kind of open up your airways. Cool beans? Yep. All right, this is the trachea right over here. We just talked about the different tissues that are associated with the trachea. We can shrink this down a little bit. No, we're not there yet. So y'all have heard of a tracheotomy or tracheostomy before? I think we just talked about this before. So this is a procedure that many of you have probably seen before, either in real life or in medical shows. And what happens here is that we're making an incision into the trachea in order to help this patient breathe, usually. All right, so I'm gonna play a quick video on that.
Interchangeably by many people. The normal upper airway starts at the nose and the mouth. It connects in the back of the throat and goes down to the larynx or voice box. Below the larynx, air passes to the trachea and to the lungs. A tracheotomy is typically placed about an inch below the larynx. A tracheotomy appliance, commonly called a trach tube, is placed through the hole, and a cuff or balloon at the lower end of the trach tube may be inflated to seal the airway around the trach tube and force air to go into the lungs when the trach tube is hooked up to a ventilator. When the cuff is not inflated, air may pass around the trach tube and may even pass to the upper airway and out the mouth. This can allow a patient to speak when a trach tube is in place, as long as there is enough space around the trach tube and in the upper airway for air to pass. There are several reasons for performing a tracheotomy. Sometimes tracheotomies are performed for more than one reason at a time. The most common reason is to allow for long-term ventilation. This is usually in the setting of a critically ill patient in the intensive care unit who requires mechanical ventilation from a ventilator for a long period of time. The purpose of this is to avoid the discomfort and potential for injury associated with a tube that crosses the larynx and rests against these tissues for a long period of time. Another advantage is that it decreases the distance air needs to travel from the outside world into the lungs, which can help weak patients breathe more easily and possibly come off the ventilator more easily. While the ICU is the most common setting for long-term ventilation, it is also seen in patients with chronic neuromuscular disorders like muscular dystrophy and spinal cord injury. In these cases, the cuff may be left deflated to allow the patient to more easily speak or swallow if they are otherwise able. Upper airway obstruction is another common indication. In this instance, the tracheotomy is done to bypass the obstruction that may be preventing adequate air from reaching the lungs. Causes of obstruction that are seen most often include large tumors, severe scarring, or bilateral vocal fold immobility. Additionally, patients with severe obstructive sleep apnea may be treated with a tracheotomy.
Yeah, another reason why that might happen as well is, let's say somebody gets into a terrible accident where, I don't know, something really falls on their face. And so maybe it could be that the structures of their nose or mouth are just completely destroyed. And so they can't breathe properly. So this could be another reason why you might want to perform a tracheotomy, just because everything here is just all messed up. That could be another reason why. Okay, everybody cool on that one? Tracheotomy? Yep. All right. I'll keep going till 12, till 1, and then we're done. Okay. All right. So again, that's going to be the trachea right over here. Typically, that stoma, or the hole that's made into the trachea, are going to be in between the second and fourth tracheal ring. So a couple inches below the laryngeal prominence and above the sternal notch. Okay, right over here. Bronchi. Oof. Okay, now we're going to talk about bronchi. Now, bronchi, if I kind of blow this up over here, bronchi are going to be the branches that come off of the trachea. Okay, bronchi are the branches that come off of the trachea. Okay, so we should know that bronchi is going to be plural, and bronchus is singular. Bronchi is plural, bronchus is singular. Okay. What I'm drawing in red here is what we call the primary bronchi. Okay. These are the primary bronchi right over here. So I'll do with the P, primary bronchi. In green, we have these other branches coming off called the secondary bronchi. Okay, so this is all secondary. And then when you finally get to your third division, all the way down over here, like these guys here, 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 okay? Those are called your tertiary bronchi. Okay, primary, secondary, and tertiary. I don't have orange. Okay, so just find your initial bronchi first, right? And then branch off and branch off and branch off. Okay, everything beyond the tertiary bronchi are going to be called bronchioles. Okay, everything beyond the tertiary bronchi are called bronchioles. So all these little branches out there, they're all called bronchioles, 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 bronchioles. So everything in blue, let's make it blue. Here, here. Okay, those are all bronchioles. All right, questions on the divisions of the bronchi? Everybody cool on that one? Jeez. Okay, I think I'll stop right there. Again, I want to give you all time to kind of look at those